Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting firm focused on improving the strategic, financial, and operational performance of provider organizations. On this program, we will explore trends and share valuable insights on how health systems and medical groups can optimize their performance to meet the demands of this increasingly complex healthcare environment and shift to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. Daniel has been in the industry for over 3 decades and specializes in shaping strategic initiatives for organizations in areas such as population health, clinical integration, physician alignment, information technology, and data analytics. For additional insights, visit luminahp.com and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. On today's episodes, we're going to dive into the new team model that was recently released or has been discussed with CMS. For those of you that don't know about TEAM stands for the Transforming Episode Accountability Model. It is a 5-year mandatory episode-based pricing model, very similar to the bundle payment model or BPCI or BPCIA that was released a few years ago. It's sort of the next version of that. And in a lot of the conversations that we've had with a lot of our hospital leaders and CMOs and so forth, they know that this was coming. They have an idea of sort of what TEAM is, but they're really not sure what to do about it. So we thought on today's episode, we're going to dive into it. And we're going to talk about where it's at and how organizations, how hospitals really do need to start to prepare for it. So what is the TEAM? What is TEAM? What is it based on and the surgical episodes? Well, it's based on 5 surgical episodes. These are the high volume, high cost surgical procedures that are done in the hospitals. So the first one is lower extremity joint replacement, LEJR. Second is surgical hip/femur fracture treatment. Third is spinal fusion. 4 is coronary artery bypass grafts, CABG. And 5 is major bowel procedures. All of those, again, are usually the top episodes. The one that sort of stands out when I talk to a lot of healthcare leaders is the femur fracture treatment. That's not necessarily in the past been that much of a episode-based component. Certainly hip replacements, knee replacement has. So this is going to be a little bit new for organizations. So a couple of things that are interesting about this, the way that CMS is pricing this, again, it's an episode-based pricing model. So the thought is that there's going to be one fee or a reconciliation of that fee for surgeons, for the hospital, for anesthesiologists, everyone that's included within that patient episode. And the time period goes 30 days before the episode and then 90 days after the episode. Participating in TEAM is mandatory. They're making it mandatory for right now 741 acute care hospitals across the country. And they've identified that within 188, which they talk about as core-based statistical areas across the United States. And they're defining these core-based areas as those that have historical spending patterns, in some cases a little higher than others, hospital characteristics, if some of them, let's say, have higher readmission rates than others, as well as those that have been involved in the CMS bundle payment process in the past. So you can see there's a lot of components to this, and there's a bunch of unknowns right now. And interestingly enough, this does start on January 1st, 2026. But they're using this last 2 years, certainly as the look back period. So some of what we've already done, some of what has been captured within HCCs and so forth are going to go into the risk calculation. The other point is that we just finished the comment period. So they had a comment period of a couple of months that concluded on June 10th. I have some preliminary information that was actually released by Dr. Mehmet Oz. He launched or participated in the Healthcare Transformation Task Force, and they released comments a couple of weeks ago on the status, kind of clarifying a couple of the components of TEAM. Well, here joining me today is my colleague, Lucy Zielinski. Lucy is an absolute expert when it comes on HCC and certified coder. She's helped numerous organizations in a lot of their clinical documentation redesign, particularly in the ambulatory area. Lucy, welcome.
Thanks, Dan. Thanks for having me on.
So, Lucy, when I look at the aspect of TEAM, there's 3 components that sort of resonate for me. One is the financial implication, right? What does this mean for hospitals? How do you identify that baseline? What's that overall impact to not just the hospitals, but to the surgeons? That's the first thing. The second component is really around the quality, the performance measures, right? So there's quality outcomes to it. There's performance outcomes that are associated with that. And then the third is process, right? It always comes down to process, right? So what do the hospitals need to think about doing differently than they're already doing to maximize what the impact's going to be? So let's start with the financial piece. And maybe I could throw a first question out for you. I know that capturing the HCCs is critical, right? Because that's going to drive the risk level. That's going to help to guide patients all the way through. Talk a little bit about what you've seen on the HCC capture related to team.
Sure. Dan, as you mentioned, that piece is very critical. There are three tracks, and that adjustment could be as low as 15% reduction or plus 10 on the upside. And there's a calculation they're calling target price. And the HCCs are part of that. So they're taking this regional price for certain MSDRG or HCPC codes. They're multiplying times this patient hospital specific adjustment. And that's where HCCs really go in. They do that look back. They're proposing taking
Yeah.
a look back 6 months, right?
So that 24-month periods is the baseline, but hospitals have an opportunity right now to go back in that 6-month period before January 1st, which is really going to be July 1st, right? And to make sure that all the HCCs are captured.
Yes, so if they don't have a CDI program in place already, it is really critical that the providers, hospitals, providers, primary care physicians, the surgeons have a CDI program in place to capture the HCCs, and not only the HCCs, but that social risk
Yeah.
score as well, just to make sure that that is being captured in this year, in 2025.
So I know from a finance standpoint, there's three tracks of participation, right? So those that are, let's say, mandated of the 741 hospitals, but do not have a track record of being involved in BPCI or any of the underbundle, they're going to enter into track one, and there's no downside risk. There's no lower performance year. It's basically the first year just to kind of get your feet wet. But those that have a history are going to be entering into track two and track three. In track two, there are lower levels of risk with some opportunities for the upside. But then in track three, that's the highest one, right? So they're going to, hospitals who have a history, they're going to automatically be in track three. I've heard, and in some of the basic calculations that we've done, it's a pretty good swing. It could be anywhere from, 2 to 5,000 on the low side to 2 to 5,000 on the high side. And basically what that means is if the hospitals come in below what the total cost of care is, they're going to have to write a check versus if they were going to perform better, then obviously then they're splitting the savings. Is that what you're seeing as well?
Yeah, that's exactly right, Dan. So there's hospitals may take a hit as well as even the providers
Yeah.
if that's being passed down to them.
Well, and that's a good point because you have to remember we're looking at total cost of care. And sometimes it's really difficult for hospital leaders to kind of get their arms around, well, what is included on total cost of care? And it's really coming from the claims data, right? So if you're looking at what the costs are 30 days prior to the episode, right? And the episode is the surgical episode, versus the cost 90 days afterwards, that's that total cost of care. So I think it's going to be really important for hospitals to understand what their efficiencies or inefficiencies are as we talk about perioperative in a few minutes, but more importantly than what the financial implications are to that total cost of care figure.
Yes, and that's why I think hospitals should be doing an impact study to determine what kind of hit they may potentially take because of this.
Yeah, absolutely. Absolutely. Because, as we talked about, it could be quite great. Let's move into a little bit of some of the performance assessments. So, like with many of the value-based care programs, it's not just based on shared savings, it's not just based on improving, costs and so forth. Quality and performance is a critical part of this, right? So although you may do really well on the cost and reducing the cost, if you don't hit your quality thresholds, you're going to be limited in realizing some of your potential savings. From what within the initial information that was released on team, there were three areas, Lucy, that I've seen that are really critical on evaluating the performance. One is tracking all-cause readmission rates, right? And this is something hospitals have struggled with and have been struggling with for years. I think the second is around patient safety indicators, and then patient-reported outcomes and based on those episodes. And from what I'm seeing, they're really focusing a lot on the lower extremity joint replacement in terms of the patient outcomes there. So, Lucy, given those three assessments, anything else you would add?
Yeah, Dan, so many, as you know, many hospitals are already tracking those. I think what's important is that they tie them back to those episodes and intentionally take that data and do an analysis to see how they're performing against those measures. And there's another thing that I thought of. One of the other measures that many organizations track is the transitional care management visits, the TCM visits that are occurred within 14 days post-discharge. Although that's not part of this model, but that will provide many organizations some insight into how they're doing.
Yeah, that's a great point because a lot of them, I think transitional care management is now starting to pick up. And many of the hospitals have done a good job with discharge management, but not necessarily with transitional care management. But, I can't help but think, Lucy, this has to start really in the pre-surgical evaluation, right? So it's going to be so important for these hospitals and the pre-surgical evaluation team to properly screen the patient, identify the risk level, code for it appropriately, and document it for appropriately, so it carries it all the way through the whole perioperative continuum. So by the time you do get to that transitions of care, you have a sort of a patient-specific, risk-focused care plan that can help transition that patient back to the home environment. And then you're able to manage not just to the needs of the patient and the caregiver, but specific to the risk factors that are inherent in that patient.
Absolutely, Dan. It goes back to what we said earlier, that HCC must be captured. That's very important. In addition to that, there needs to be a health-related social needs screening. That's part of the model requirement. So beneficiaries really need to be screened for some of these domains. And here's where hospitals really need to understand the social determinants, because those determinants can really impact the outcome of the patient. So HCCs, performing the screenings, having that as part of the pre-surgical evaluation process is very key. In addition to that, even that care coordination is important. And I mean, I can share a personal story here regarding that.
Yeah, if you're just turning in today, I am Daniel Marino, and you're listening to Value-Based Care Insights. I'm talking here today with Lucy Zielinski, and we're diving into the team model that was recently released by CMS. It's the Transforming Episode Accountability Model that's going to impact 741 hospitals around the country. Yeah, Lucy, I know you mentioned that before, that you have a personal story on how maybe patients or one hospital didn't necessarily do a great job on their pre-surgical evaluation, and it really caused some challenges to the patient once the patient was released from the hospital and they got to the home environment. Maybe you could share a couple of those key points with us.
Sure, sure. So this was actually a real thing that happened to one of the neighbors here. She's a 67-year-old female, widow, living alone, who is on a limited income and happens to be a diabetic. And she had knee surgery in an ASC and was sent home that same day. As you know, that's what happens these days. She had some help in the home from others, but really not enough. And for a myriad of reasons, her physical therapy was delayed for over a week. She couldn't get around to ice her knee as it was directed. I think it was like every hour or something like that. She ended up developing an infection. So then it was just a mess. And she tried getting into a rehab facility for physical therapy, for some treatment, because she didn't have the appropriate caregiver resources available to her. and it was denied.
Hmm.
So, as you can imagine, Dan, her recovery period lasted longer than was anticipated, but even more, unfortunately, it resulted in complications, which resulted in her total cost of care probably more
So
than
she ended
if
up
she
having to
went
go
to
back.
rehab.
Did she go back to the hospital? Was she readmitted, or did she go to the ER for evaluation based on her infection?
She went to the ER, then saw the orthopedic physicians a few times. They redid some stitches and some other treatment. So a lot of this, as I heard this story, I thought to myself, this could have been prevented if there was this pre-surgical coordination of care plan developed early on to ask her those critical questions. Will you have the right care at home,
Right.
right? And put a plan together.
Absolutely. Well, as you know, we're working with hospitals around the country on this perioperative services value stream. And to your point, the critical component of that is the preoperative evaluation that has to occur with the patient. And hospitals for years have focused on improving efficiency in the OR, and that's important. We've done a lot of those types of engagements. But when you think about it from a value-based care perspective, and certainly in the impact of to team, you have to think about the pre-evaluation or the pre-admission testing, whatever you want to call it. You have to think about it differently. We have to focus on the risk levels of the patient and all of those elements, like you said, the social determinant pieces of it, whether they have the right support structure at home with the caregivers, as well as then arms around or getting our focusing our attention on the comorbidities and a lot of the chronic diseases and so forth. If we can do that preoperatively, not only does it reduce then the fee for service components within the surgical episode, right? Cutting down on the cancellation rates and all that other good stuff, but it really does drive the performance post-operatively in terms of being able to support the care plan. But more importantly, as the patient transitions to home, right? There is a focused care plan with the patient on how they need to recover. And it seems like a lot of that is missing.
Yeah, and one of the things, Dan, part of the model, the requirements is that a referral to a primary care physician, it's required before the patient is discharged. And that really promotes continuity of care and a good, solid, successful transition.
Yeah, you're absolutely right. And that's a big change too, because a lot of times when a patient goes in for surgery, it's the consult or the surgeon, right, that is processing the pre-auth and they're kind of managing the case. They may get it, communicate with the primary care physician, but not to the level that they're going to be mandated now. So that has to be part of the preoperative program, as well as then the postoperative care and recovery and transition back to ambulatory.
Mhm. Absolutely. And you
So
talked
let's
about, Dan, operational changes that need to happen, and that's definitely something that I would recommend is forming a really a work group that is not only involving that surgical service line, but a team from the clinical, the finance, quality, analytics, care management, and even value-based care components uh, to to assess how does the healthcare organization succeed under this program.
Yeah, you're absolutely right. I think in order for hospitals to really understand how they need to evolve their overall procedural service related to these 5 episodes, if you will, you need to have a multidisciplinary team that's going to participate in it. And one thing I do want to make mention because we've worked on this, I'm really proud within Lumina that we have a lot of tools. So any of our listeners out there that are interested, we have a team readiness assessment tool, which is great because it's something easily that organizations can start to look at. It looks at the financial component, it looks at the performance and quality component, and then it looks at the operational requirements that helps to understand areas of vulnerability and really where to focus attention. The other thing that be happy to share, and this is free, is our perioperative services value scorecard. The scorecard has been great, Lucy. I mean, a lot of people can self-evaluate and determine, well, are they strong or are they struggling within preoperative services or postoperative care or the recovery piece? And the nice thing about that is it measures it against benchmarks.
Mhm. Yeah, it's a great tool, Dan.
Yeah. And I think the key is when you think about the assessments, wrapping that into how you need to operationalize it, right? How we need to then incorporate it into our performance drivers. And it starts with gathering the team. But I'll tell you the other piece that, and we talk about this all the time on this program, if you really want to make the change, you have to align the incentives, right? And one of the things that I think will be coming out of this team model is for organizations to think about how they can create a funds flow model or some type of an incentive based shared savings component that incorporates the surgeons, obviously with the hospital, post acute, and even some of the hospital based specialties like anesthesia, which typically aren't involved in value based care at all.
Right, right. So it's developing a model and really educating them. So there is collaboration across the whole continuum. One thought I had, Dan, is as this model expands care coordination, as you know, a lot of these services are billable to Medicare, and they could provide an enhanced revenue stream to the organization. So that some of that could then be distributed in an incentive-based model, depending on how the organization performs.
Well, and that's a great point because when you think about that, if you have a robust pre-surgical evaluation process and you're able to identify the risk conditions, and let's say the patients do have chronic diseases or comorbidities, that could feed not only into your transition to care model, which you're able to bill, you could also bill CCM for that. Or you could build
Exactly.
PCM for that if it's really based off that single specialty, which many ortho practices are doing right now.
Well, and Dan, in my story earlier with that diabetic patient who had the knee replacement, I think what an opportunity. If she was receiving care management services, her complications could have potentially been avoided because
Yeah.
somebody would have been involved in her care.
Yeah, I absolutely agree with you. The other thing that I'm seeing too is there's a lot of technologies that are coming out right now, and the technologies really around AI, my personal opinion, it's really going to be a game changer for a lot of care management programs. And we're going to have on the show in another couple of weeks Dr. Christian Payne. He is an orthopedic spine surgeon from Duke, and he leads a technology called Revel AI. I've been really impressed with it, Lucy. It has an opportunity to aggregate a lot of data, social determinant data, claims data, and so forth, that helps to drive a lot of the risk activities pre-surgical, but that really then follows the care management process in support of the surgeons and then the hospital team as they transition from the hospital arena back to the home environment. So I'm really excited about that. One last question for you. When we think about the HCCs, and I know this is an area that's near and dear to your heart, when we think about the HCCs, how much of the documentation, how much of all of the restructuring and the pre-surgical evaluation, how much of that needs to be done, right? So, I mean, surgeons typically haven't done a good job of capturing it, right? I mean, I would think if there's a place that hospitals should start, right then and there, it should be on identifying where they're at on their capture rate of their HCCs.
Yes, and this is your technology strategy, right? What kind of information is being shared with the surgeon? How is care being coordinated between the primary care physician, the pre-testing, the pre-op clearance from the primary care physicians? All of that whole process really requires the providers to capture those HCCs.
Yeah.
And that then would drive some of the target pricing too in the team model.
Absolutely.
which is so critical.
And the risk level. I think if there's one takeaway from our discussion today, again, it gets back to that point where physicians, hospitals, they have to really focus on their providers on the HCC capture rate. Well, Lucy, I want to thank you for joining today. This has been great. I'm excited for where this is going. I like all these value-based care programs. As I've said time and time on the program, I really feel like value-based care and the changes that we're seeing, that's what's really going to help us continue to provide good quality care and reduce some of the costs, or at least slow the growth of costs. So I'm excited about the team model.
Yeah, I am too, Dan. I think this model really aims to promote just better care and the overall patient experience. Again, going back to that story I gave, if we could change those stories for patients across the country, uh, it's a movement in the right direction.
Yeah, absolutely. Well, for any listeners out there that want to get in touch with you, maybe can you give your email?
Sure, it's L. Zielinski at luminahp.com.
And I think everybody knows mine, dmarino@luminahp.com. And I would encourage any of our listeners, reach out, especially if any of your hospitals are one of the 741 mandated team hospitals. Reach out. Let's have a conversation. Happy to answer any questions, or if anything, just sort of brainstorm where you need to start. And then, as we talked about here, we have a lot of tools. So there's no sense reinventing anything. I think to be able to incorporate some of these tools will help your team move a little bit faster. So I think with that said, thanks again, Lucy, for tuning in. I really appreciate it. And thank you for all of our listeners. Until our next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organizational performance? Visit us at luminahp.com to learn more about our consulting services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. For more information about value-based care insights, visit the programs page on healthcareradionow.com or luminahp.com. Join the conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next value-based care insight, stay well.